Good afternoon or good evening in some parts of the world. My name is Dr. Dheeraj L, and I'm here to discuss a little bit about principles of anesthesia in older people. So why have we decided to do it today? Just because it's the International Day for Older People, and I think there won't be any more appropriate time for us to discuss this topic. Now, one of the themes for this year is resilience of the aging population. You know, we are finding that older people are living longer, they're aging a lot better, and they are leading a more. So, what are the common procedures we might expect an older people to come from? By far, we know that the human body has not been made to last as long as we are living nowadays. So we do have problems with our bones and our joints. So joint arthroplasties are the common procedures they come from. If you live longer, there's a higher chance that you get cancer. So cancer surgeries are very common among the older people. Fracture neck of femurs is one of the most important and tricky cases you might face as an anesthetist. And of course, there is a variety of urological procedures for which older people come from. The disadvantage of being born as a man is that you're going to have a prostate, and every time you grow older, the prostate's going to give you much more problems. Now, there are certain risk factors which make this patient population very unique. Gradually over the years, we've seen an increasing in elderly trauma patients. They have age-related decreased physiological reserve, so we know that their pulmonary functions are not as what they used to be. We know they have cardiac problems, ischemic heart disease. We know they have CKD, and almost every organ in the body is affected. Because we are living longer, we found that people are having multiple comorbidities. The older you get, the higher your chance of getting cognitive impairment or sensory impairment. Frailty is a realistic problem among the older people. And this thing, polypharmacy, I think this probably is one of the most important things. Because people have multiple comorbidities, they are on multiple medications, and most of this time you will find that there are multiple interactions, some unrecognized. So polypharmacy contributes to a lot of problem by itself. And older people don't tend to eat as much as we do because of decreased appetite. As you grow older, you also have loss of muscle mass, so you've got decreased albumin, and malnutrition is common in this group of patients. Frailty has been getting more and more recognition as time goes on. And what is important to understand is after we had COVID, frailty has been started to be recognized as a major problem in the elderly. Frailty has been in the past recognized as an independent factor or for morbidity and mortality in this age group. This paper actually has found the association of modified frailty index with 13-day surgical readmission. So what do we do in the preoperative stage? Most important thing I think which has come or revolutionized our practice on doing surgeries on older people is what we call as an orthogery, or they like to be called as doctors for older people now, or the POPS review, where there is a perioperative older people service. They look at the patients and they optimize them. Pre-optimization is something we can do before any surgery. Risk assessment is absolutely important. Make sure these patients are not fasted for long, minimal fasting. Prompt surgery. If you are going to go do a surgery, you have pre-assessed them, you fasted them, then make sure you get the surgery done on the day. And avoid of drugs such as benzodiazepines and anticholinergic drugs. Now, if you are in a country which has got what we call as do not resuscitate orders or a treatment escalation pad, or in the UK at present we use what is called as a respect form, please make sure all these are filled in before you go for surgery. However, a caveat to this is that the Association of Anaesthetists in Great Britain and Ireland recommend that if you're actually having a surgery, if you have a DNAR form, then for the duration of surgery, you might need to suspend it, or on the 24 hours following surgery, you might need to suspend it. But follow your local policy, whatever that is. The orthogeriatrician or POPs review is becoming more and more important as days progress. They have been shown to increase the length of stay, significantly reduce complications like delirium, cardiac complications, problems like incontinence, which are recognized quite quickly. They also help in doing things like medication change. If we have not recognized a certain pathology, they're very good at diagnosing cognitive problems. So if a social work referral is needed, they're very good at that. And they generally communicate better than us when it comes to communication with family and carers. They institute measures to prevent delirium, and they aid in better discharge planning. So if you're having a doctor for elder people in your trust or in the hospital you work, we would advise strongly to get a referral from them before you go for at least a major surgery. Pre-optimization, a very buzzword. Yeah, do that in the young. We can do that with patients with cardiac and pulmonary comorbidities. It has its role in the elderly too, because quite a lot of patients who come in for surgery, quite a lot of older patients who come in for surgery have some common themes in them. Many of them are anemic, and correction of anemia is very warranted. Electrolyte disturbances, especially because of polypharmacy. Many of the people are on treatment for conditions like hypertension, heart failure. They are on diuretics, and they can have significant electrolyte imbalances. Many of our patients are now on DOACs, things like stroke prevention, or people having atrial fibrillation, they would be on DOACs, and this definitely interferes with a lot of surgery. Many of them have recurrent sepsis, like urinary tract infection, so it's very important to recognize. For example, if you actually have a patient who comes in with a fracture neck of femur, usually we say that these are patients who are medical patients. They have an underlying medical condition, and that is the reason they have been admitted to you in the first place. They might have simple things like urinary tract infection, which might require an antibiotic course for 5 days, and the patient's absolutely all right. But that doesn't mean that you cancel the surgery or postpone the surgery because they are having that urinary tract infection. Most of the times, these have to go hand in hand. Treatment of uncontrolled diabetes. We're having newer antidiabetics which are coming in. In a recent talk which we had given on gas, we had said how some of the new agents can have their own complications like euglycemic ketoacidosis, and this is worsened with the duration of fasting. But they also don't eat a lot, so they can have starvation ketosis. Treatment of acute or decompensated heart failure is very, very important, because decompensated heart failure by itself is an independent predictor of mortality. They may have tachyarrhythmias or bradyarrhythmias. Some enjoy the tipple a little more than the others, so they might have withdrawal symptoms. The hypertensive and management of hypertension has to be given importance. And one of the things which you have to be very worried about in patients undergoing, especially cemented procedures, is pulmonary hypertension, because having cement and sudden increase in pulmonary pressures are usually not a very good combination. We should risk assess these patients. Just because we can do surgeries doesn't mean we should do surgeries. There's a very interesting patient from Atul Gawande, and it's quite sobering too, because if you actually look at this, they found out that more than 1 million elderly patients who underwent surgery in 2008, 32% underwent a surgery in the last year of life, which means they had the surgery and they died within a year. 18% underwent a surgery in the last month of life, which means that they had the surgery and they died within a month. And 8% of the patient underwent a procedure in the last week of their death. If you actually look at 1,800,000 patients, that means close to 180,000 patients underwent a surgery and did not survive for a week. So we need to be very, very careful when we anesthetize these patients, and we need to stand back and ask a question: is that surgery really essential in those cases? So there are various ways of hip stratification. I mean, if you're having a fracture neck of femur, the commonest thing which we use is what we call as the Nottingham Hip Score. NELA has come up with what we call as a NELA score, but that's commonly used for laparotomies. I like the score. It's from the College of American College of Surgeons. Uh, you know, you can use it. It's a freely available resource. It's slightly, more extensive. You have to enter a little more data than you would have to use with Nottingham Hip Score, but that's the reason you come up with a very good what do you call it, risks which are specified in terms of percentages. For example, if I take this patient, what I've entered the details, it says like serious complication, the patient's risk is 44%, and the average risk for someone else would be 12%. So if I talk to my patient, I tell them that you are 4 times higher of getting any serious complication. So if you look at death, it's 3% compared to 45%. So if I were to talk to this patient and I were to explain to them what happened, I would say that in your case, the chance of death is 15 times more than what it would be for a person of your age without your comorbidities. Avoid prolonged fasting. It's very interesting. I was in a Royal College a seminar yesterday where we were talking about updates, and one of the updates was about sip till send. I mean, we do practice, or we've tried to institute this at our institution. There's multiple evidence now to say that you can actually have water till you send for the patient. It is not associated with any higher risk of regurgitation. Having or giving a patient small allocates of water, maybe allowing them to sip around 100 ml every hour is quite safe practice. I mean, the people who started this practice almost give 170 ml. But the caveat is you've got to be sure that they are not at risk for aspiration, or they do not have any factors which make regurgitation possible. But fasting or reducing the amount of fasting period in the elderly is especially important because it can be associated with an increased risk of delirium, as well as people have higher satisfaction if they're allowed to sip water till they go in for surgery, and they do, although there's not much evidence for it as yet, but I'm sure there will be as time comes on, that they have a faster and a better recovery. Postoperative cognitive dysfunction. You got to remember that cognitive impairment is not just a condition, it's a comorbidity, and you got to treat it as that. In the new ASA gradings, we know that any kind of mental illness puts you from an ASA grade 1 to an ASA grade 2. And the problem with cognitive dysfunction is that it is associated with a higher risk of death, an increased length of stay, a poorer functional outcome or delirium, institutionalization, and probably admission to a care facility post-op, and it increases the incidence of refractures probably by falling. And if you actually have got refractures in a prosthesis which is already there and you get a periprosthetic fracture, that could be quite dangerous. There is a new nomenclature which is mentioned for postoperative cognitive dysfunction or postoperative delirium. The new proposed nomenclature is perioperative neurocognitive disorder. These are classified as minor or major, and they would have a maximum tenure of 12 months, because after 12 months you can't call it as a perioperative neurocognitive disorder. You have to come up with some other diagnosis. I'm not going to go into this much more because I know there's an entire talk which has been planned by Guru to talk about this, and that's the reason I'm not going to talk further about this. But fast track surgery, monitoring depth of anesthesia, adequate management of pain, that's what it should be written there, and continuous intraoperative analgesia are quite important. This is a very small guideline which we have in our trust for how to manage patients on DOAC. Have a guideline like that for you when you deal with elderly patients who are on DOAC. If you actually have to give anything like neuroaxial blockade, please follow whatever is your local guideline, or there are guidelines from the AAGPI, there are guidelines from Australia as well as America. These are very, very good guidelines. Have a look at them and then go for that. But if you're actually having a patient who has come in with a fractured neck of femur, then postponing the surgery just because the patient's on an anticoagulant is no longer acceptable, because the morbidity and mortality is greatly increased with delay. It is a time sensitive surgery, and there have been multiple studies which have been showing that if you postpone surgery greater than 36 to 48 hours, your chances of having morbidity and mortality actually grows like the curve which we have, for CO2 and brain. So, what are the intraoperative considerations in this patients? Well, the type of anesthesia is absolutely important, or is it? When there's a considerable amount of work going on in the background, whether regional is more useful than general anesthetic in this group of patient. Restrictive transfusion triggers are important because giving people blood exposes them to the risk of multiple problems. So unless they require it, we shouldn't be giving it. Monitoring to the depth of anesthesia. Is there any role of goal-directed therapy? Maintaining homeostasis, prevention of acute kidney injury, and continuous analgesia, including multimodal analgesia and opioid reduction strategies. So let's talk about the first thing, regional versus general anesthetic. I mean, the amount of time people say, oh, I want to give a spinal, that's why I'm going to postpone the surgery because the patient's on anticoagulant or some reason. I think we should stop doing this because, frankly, there's no difference between regional and general anesthesia and the effect on at least 30-day or greater mortality. So there was a large Cochrane review which was done by Gay and Parker, and they looked at anesthesia for hip fracture surgery, especially whether spinal made a difference as compared to the GA, and they concluded that there wasn't much difference. This was another study which was done where they looked at general versus neuroaxial anesthesia and hip fracture, a systemic review and meta-analysis. And in this, if you actually look at this forest plot, there was no influence on the 30-day mortality at all if you either gave a general anesthetic or you gave a regional anesthetic. However, when they looked at length of hospital stay and in-hospital mortality, that means patient dying before the patient was discharged, then of course there was a greater trend of benefit towards regional anesthesia, and there was also a greater trend of benefit towards regional anesthesia when you looked at length of hospital stay. But as I said, overall on 30-day mortality, it did not make a difference whether you gave a spinal or a general anesthetic, and hence you can conclude that it really doesn't make a difference if you give a general or regional. I have been practicing anesthesia for more than 20 years, and I probably would have given spinal to less than 5% of my fracture nerves. My choice of a procedure is always a supraglottic airway, giving a general anesthetic with fascia-iliaca block. But a lot of my colleagues give spinal, and there's nothing wrong with it. But we just have to move away from this thought that spinal anesthetic is the best form of anesthesia for these patients. Depth of anesthesia monitoring. It has been shown recently that the more deeper you keep patients who are elderly, the worse their outcome is. And this was a study which looked at, you gave a spinal anesthetic in the elderly patients who actually have a hip fracture, and then you give them a sedation. So what is the depth of the sedation? So it showed that in patients who actually have multiple comorbidities, we have a system in UK which we call as Charlson's Comorbidity Index, which has got a few specific diagnosis brackets. And if you actually have a Charlson's comorbidity score of greater than 4, then your mortality was reduced significantly, almost by half, in patients who had a light sedation as compared to deep sedation. And if you actually look at it, in patients having a Charlson's comorbidity index of greater than 6, here, 1-year mortality, and this is not just immediate mortality, 1-year mortality in patients in the light sedation group was 28.6 as compared to 52.6. And we know this from a long time, and it's just not, I don't think so it is just applicable to the elderly patients, but the depth of anesthesia, once you start dropping your BIS score to less than 25, that is associated with increased morbidity and probably mortality in some group of patients. So this graph again is from the same study. It shows light sedation and deep sedation here. So this is deep sedation, this is the light sedation. So if you look at patients who have got a Charlson's comorbidity index of greater than 4, you will see that patients with deeper sedation do worse than patients with light sedation. So what do we use? How do we monitor the depth of anesthesia? Does using BIS make any difference, or does it prevent delirium? This was a very small systemic review, just having 2 studies which was done. But the thing to notice here is that both the studies showed that there was a favor towards BIS guided depth of anesthesia monitoring and a reduction of delirium in the elderly population. So I think going forward, maybe this is something which we need to consider. Now, we know that perioperative hypotension is associated with an increase in postoperative morbidity and mortality, but the appropriate management strategy for this remains uncertain. So this was a study which was done where they actually had an individualized management strategy based on each patient. So they either treated the patient for a drop in their blood pressure of around 10% from their reference value, which is patient's resting systolic blood pressure, or they went ahead with the strategy of giving allowing the blood pressure to drop below 80 and then treating. So in the first group they used noradrenaline to treat the patients, as well as in the second group, but they were treated only if their systolic blood pressure dropped to less than 80. And the results of this trial was quite shocking. And if you look at the probability of postoperative organ dysfunction, okay, you found that in the group which were individualized treatment was much lower than the group which had standard treatment, which made the authors conclude that, amongst patients who predominantly are undergoing abdominal surgery, this was an abdominal surgery, who are at an increased risk of postoperative organ dysfunction, especially renal dysfunction, cardiac dysfunction, just having just making sure an individual systolic blood pressure management resulted in better outcomes and lesser organ damage. Now, we know the elderly patients run themselves dry, but what do we do with these patients? Do we give them more fluid or not more fluid? It is quite difficult, not just in the elderly, but even in the younger population. And this was a very big study called as Relief Trial, where they randomized 3,000 patients to either liberal or restrictive fluid strategies intraoperatively and 24 hours later. And this is what they found. They found that there was no improvement in mortality and hospital stay. There was an increased incidence of AKI and surgical site infection in the restrictive group. They said that it's probably better to use a zero balance rather than a restrictive approach. Use of goal-directed therapy in theatres has increased ever since the enhanced recovery practices started taking place in our theatres. And is this something which we should be using in the elderly? My frank opinion is yes. This was a study which was called as the Fedora trial. In this study, the aim was to actually evaluate post-operative complications in patients having major elective surgery. They used the esophageal Doppler. They used goal-directed hemodynamic therapy, in which the administration of either fluids, inotropes, or vasopressors were guided by stroke volume, mean arterial pressure, and the cardiac index. The esophageal Doppler monitored goal-directed therapy, they found reduced postoperative complication, it reduced the hospital length of stay, but this was in low to moderate risk patient, and this was in patients who were undergoing intermediate risk surgery. But they found no difference in mortality. And hopefully this group of patients, you would not expect the mortality to be very high, but certainly in major surgeries, it has been shown to be of benefit. So if you have a cardiac output monitor, either an esophageal Doppler, or you've got something, different like thermodilution technique, or if you have a PICO, LIDCO, or what we call as the Edwards monitor, please do tend to use them for high-risk surgeries in the elderly. This was another study which was called as the hip-hop study, where they actually found whether using growth-directed therapy was beneficial in patients having hip arthroplasties, and they found that using goal-directed therapy in hip arthroplasties reduced post-operative complication. They also caused a reduction in post-operative bleeding as well as hospital stay and ITU. This is a very simple graph which actually shows you about the length of hospital stay after surgery, and you can see this is the control group and this is the goal directed group. They have a much narrower length of stay and as compared to the control group, as well as a much lower length of stay. So we come on to the post-operative period. I think pain management is probably the most important thing. Some of the elderly patients or the older people which we deal with, they do not have the cognitive ability to ask for pain relief in a timely manner. Most of the time the delirium is confused as delirium, when it could just be very simple pain relief which could sort the problems out. So pain management is very important. Prevention of post-operative delirium, early mobilization and prevention of deep vein thrombosis is very important. Early nutritional support, early rehabilitation, physiotherapy, occupational therapy, what was required for them. Prevention of falls, please do work on this because they do tend to fall, and various strategies to employ decrease or prevention of falls, it can be quite important in the post-operative period. And where possible, geriatric centers or wards are to be there. I'm sorry, so old presentation, we should be calling them older people and not geriatric population anymore. But yeah, so wards for older people or center for older people are something which we can help with. Pain management. I mean, I'm a great fan of IV paracetamol, although it's not considered to be the most sustainable thing nowadays. But I still believe that IV paracetamol has a better profile than oral paracetamol, and I would give all my fracture neck of femurs IV paracetamol. We are regional enthusiasts in this group, and regional anesthesia is probably, I think, the most sustainable and most beneficial of all anesthetics. Avoid opioids, especially codeine, cyclizine, and especially tramadol in these patients. They don't tolerate these drugs very well. You could use PR and Oromorph as compared to Oxynorm for breakthrough pain, and avoid NSAIDs because NSAIDs actually increase the incidence of fragility fractures in patients who have undergone fracture neck of femur. So it's one thing which I actually absolutely avoid in this patient, plus causes an increased bleeding risk. Very rarely, I know we are going towards opioid-free world, but some patients may require a PCA. You could balance this of giving an opioid or having a patient in pain and delirium post-op. So preventing delirium, I'm not going to go through this because I'm sure Guru has talked to you or is going to talk to you about this, but these are very easy methods which we can use. The treatments are haloperidol, olanzapine or clonidine, but our haloperidol and olanzapine per se are not great drugs. So I think the strategy should be to prevent delirium rather than to treat delirium. Well, with that, I finished my talk. I'm sorry if that this is a recorded talk and I can't be there for any questions, but we're going to have a Q&A session later on with all the other members. If you have any questions, please ask them. For people who are watching this on my YouTube channel, if you have a problem or if you have a question with anything which I have said, please put it down in the comment section and I will make sure I'll answer that. With that, I end my talk. Thank you very much.